What's going on, everybody? Welcome to the Freedom to Flourish podcast. We've got a great episode for you, episode 77, and today we're going to be talking about anemias. We're calling it Anemias, the Complete Guide. So what we're going to be talking about today is, well, what are anemias? Everybody hears anemia, and I think it's just this one condition, when in all reality, a lot of different things with a lot of different causes, a lot of different symptoms, a lot of different classifications, and a lot of different findings on labs. So break it down and tell you guys what defines each different type, what causes it, and based off of what you have going on, what are the main things that you need to keep eyes out for, or what are the things that you need to change in order to fix your anemia. It'll be a great episode. I'm really looking forward to it. But Dr. Joel, how are things going today?
Things are well. I'm excited to be here as always with you, Dr. Tim. I appreciate you. I know a lot of patients comment on the podcast and on the episodes fairly often. So I'm thankful for both of us just taking a little bit of time out on our busy week to make this happen for people. So yeah, when it comes to anemias, I think the biggest thing that I see is there's like two different categories. There's like more of the benign anemias where patients are told by their doctors, your blood work came back, you have an anemia, you have and sometimes that's specific, sometimes it's not as specific. Sometimes it's just like your hemoglobin is low or your mean corpuscular volume is high or whatever it is. But I think there's a lot of lack of education from doctors as far as what's actually happening here. And then I think there's just a lack of knowledge as far as like what actually causes these issues. Iron deficiencies, B12 deficiencies, as we talk about so often, they don't just happen for no reason. And so we'll get into what causes them today. But there's also, like I said, the more benign areas, and then there's the more specific conditions, right? Where we get into, more of the clinical issues, which are usually much more specific, like the thalassemias and things like that. So we'll talk about the more like kind of regular, benign, not benign, but more regular, less intense anemias, and then we'll talk about some of the more specific conditions as well. So Dr. Tim, to start, and it looks like you're muted, just FYI, to start here, let's jump into like what is anemia? What are anemias, and what does it mean? Because most people, I think that anemia just means you have low iron, but what does anemia actually mean?
Well, it could be. It could be that you have low iron and that's your problem, but that is just such a small little piece of the pie chart that makes up the classification of anemias. But what anemias are is they are disruptions in your red blood cell. It can be disruption in hemoglobin. It can be disruptions in just production of red blood cells. They can be shaped funny. They can be too big, too small. They can lack hemoglobin, have too much. And it all just depends on what you have going on and what each thing kind of goes together. So there are, I guess the overarching theme is poor oxygen carrying capacity to your tissues, and therefore oxygen starvation in your tissues, attributed to poor red blood cell and hemoglobin concentration, whether it's too much, too little, you name it, all that stuff. Usually the too little hemoglobin and iron and all those things, or too few red blood cells, is really going to be the main driver of fatigue and being just tired in general, poor athletic output, things like that. In the classical, typical anemia type symptoms. But there are anemias that swing the opposite direction, that are macrocytic, where you have too large red blood cells, and they have too much hemoglobin, all those things. But it all just depends. So there are 6 major terms that we're going to use to classify anemias, and they kind of are divided into 2 different categories. One is size of the red blood cell, and 2, the concentration of hemoglobin. So the most common type of anemias that are going to lead to fatigue, poor oxygen carrying capacity, all that stuff, are going to be your microcytic, which means they are small red blood cells, and then hypochromic, which means they have not enough hemoglobin. So we have microcytic, normocytic, and macrocytic, which have either small size and volume, normal size and volume, or high size and volume of red blood cells. And then your chromic or your hypochromic means low hemoglobin concentration. That's defined by your MCHC on labs, and your microcytic, normocytic, all that stuff is defined by your MCV or mean corpuscular volume on blood work. Anyway, so the hypochromic, normochromic, hyperchromic classifications are used to define how much hemoglobin you have. So with things like iron deficiency anemia, the most common one that we tend to see and talk about, and it's just most common, especially with like young girls and all that stuff that tend to have a lot of health issues. It ends up being a result of physiologic blood loss, which every month, menstruation, all that stuff. But then also it can come about because of gastric bleeding and various other clotting disorders, stuff like that, where you're just bleeding too much and losing too much iron and hemoglobin and all those things. So that's going to be more so the microcytic hypochromic classification. But there's plenty more that go on beyond that. The main thing that we like to keep eyes out for, and the thing that we like to talk about, is it's a factor of how much oxygen you can carry through hemoglobin, and it's a factor of how big or how voluminous your red blood cells are. That is what defines the different types of anemias. With that being said, there's quite a few different kinds, so we're going to do our best to get through them without being too complex with things. So, Joel, do you want to take us through iron deficiency anemia as well as some of the other microcytic ones?
Yeah, so microcytic, remember micro meaning small, and then cytic referring to the size of the cell. So these are the most common ones here. So microcytic, so iron deficiency anemia, which is probably one of the most common ones. That one's also going to be hypochromic, which means, again, that low hemoglobin concentration. You have sideroblastic, where the iron's not necessarily incorporated into the hemoglobin. That one's going to be, again, microcytic. You have the thalassemias, which are more hypochromic, like genetic conditions. And then those can also cause just irregular cellular production with things. And then you have things like B6 deficiencies. And that's usually going to cause hypochromic issues as well. Dr. Tim, one of the things that I want to go through here as well is just kind of talking about the different nutrients that help your cells to carry oxygen. We have the microcytic list here. We have the macrocytic list, which is where the cells are going to be large. That's where the MCV is going to be large. This is usually going to happen because the red blood cells, as they are created, they're on the larger side of things, and then as they mature, they're going to essentially get smaller. And so when you have a large mean corpuscular volume, a high amount in that number, that's usually going to indicate like a B12 deficiency most commonly, but can also be related with B9 folate. And that's probably the most common macrocytic one. All these other ones are going to fall under the normocytic, which means like the cells are actually a normal size, but the overall level of oxygenation and iron and so forth is going to be off. So you have the acute post-hemorrhagic anemia, which is obviously where you're just losing blood. You have the hemolytic anemias, where your immune system is actually killing the red blood cells, or the red blood cells are simply just dying off. Lupus, autoimmune stuff, leukemia, those are some of the big ones. And then that's I think really the majority of our list. Without spending too much time on these things, Dr. Tim, do we have anything else we want to add to this list? I think it would also be great, of course, we'll get into talking about the different markers that you may also see off with some of this blood stuff. Talk about the different nutrients that are also important with carrying oxygen with the cells, the nutrients that most doctors either don't even know about or they're just not talking about it. And then the last thing is like, what usually causes these issues and how do we fix them?
Yeah, absolutely. So just want to talk about how, there's different kinds of anemias. And if you haven't kind of noticed a bit of a pattern here, there are three major kinds that can come about that are pretty common outside of iron deficiency anemia. So that obviously is going to be the biggest one. And whenever you're iron deficient, you're not going to carry oxygen. You're not going to make enough hemoglobin, all that stuff. Lead poisoning can cause that big time. same with sideroblastic anemia. So when it comes to iron deficiency anemia, you can also have sideroblastic. So with sideroblastic, all that is that you are not able to use iron properly in your hemoglobin. And so iron is a necessary component of hemoglobin to bind oxygen and carry it to your tissues. If you do not have enough B6, what's going to happen is you are not going to produce hemoglobin properly. And so that's why it's hypochromic. And so these things can go hand in hand. You can have not enough hemoglobin to bind to the iron, therefore you'll have an iron deficiency anemia, sideroblastic anemia, or you just don't have enough iron for binding to hemoglobin, and therefore you have sideroblastic anemia. It's just all about that joining of the two things. Thalassemia, you just have weird red blood cells. That's essentially all it is. Your production is funny. They're more likely to break down and burst and all that stuff. And what's interesting is it actually has the opposite effect as iron deficiency anemia in regards to iron binding capacity, all that stuff. So whenever you have iron deficiency anemia, typically you'll have low serum iron, low ferritin, all that stuff, but your total iron binding capacity is super high, meaning your body can hold on to more. It's the opposite with thalassemia. So you have high iron, high ferritin, but then low total iron binding capacity. So it's just kind of an inverse thing. But when it comes to the B6 deficiency, B6, B9, B12, for those who have been our longtime listeners, or they just are pretty well versed in the natural health realm and the importance of B vitamins, all that stuff, those are all super necessary nutrients for methylation. They're super necessary nutrients for hormone breakdown, super necessary for antioxidant production, histamine breakdown, you name it, all kinds of stuff. And so if you have chronic insulin issues, chronic cortisol issues, chronic hormone issues, you're going to be very, very likely, or maybe not very, very likely, but much more likely to have some sort of B6 anemia. You're going to be more likely to have B9, B12 anemias. You're going to be more likely to have all sorts of these problems. So with how we're going to talk about how to fix these things, we're also going to talk about what are the things that are going to fuel the fire that's going to deplete you of these resources required to keep you from getting these anemias. What depletes you of resources to produce sufficient right size, right concentration of hemoglobin and red blood cells. Anyway, with that being said, let's get into the more clinical stuff. So when it comes to iron deficiency anemia, we just had a good conversation about this before we started. What do you find to be the most common things that will contribute to that?
Yeah, I would say number one by far is going to be infections. And this is where I think so many doctors really miss the mark. And it's really unfortunate, actually. So when you have an iron deficiency or a B12 deficiency or B2 deficiency or a copper deficiency, all of those things help your cells to carry oxygen. And they're usually going to be deficient because of infections. So those infections could be bacterial infection, could be fungus or candida, could be parasites. And so no matter what it is, whether it's one of those or two of those or three of those things will generally feed on those nutrients and cause those deficiencies. And what's the number one treatment or recommendation when you have low iron? They give iron. And so what it actually does is it actually ends up feeding those infections, usually making things worse. And that's why, Dr. Tim, as I'm sure we've both seen, patients come in with these different anemic conditions. They've taken iron for forever, and guess what? The numbers haven't changed. And part of me, and like the common sense side of me, wants to say, like, okay, if it's not changing and it's been like 6 months, maybe it's not helping. And then, one of the biggest questions I'll ask patients too is, okay, since you started on this, like, how do you feel? Do you feel better? Our function and how we feel, our energy, our sleep, our stress, all these things functionally should be improving if our body is healing itself and if we're doing the right things for our body. And so when it comes to infections, we talk about infections all the time. We talk about how a lot of infections are in the gut health. Sometimes they can just kind of be throughout the body in different ways. I've seen a number of times where, someone's SIBO or SIFO, small intestine bacterial overgrowth, small intestine fungal overgrowth, is causing these issues. I've seen parasites quite a bit cause these issues. I've also had some patients that had some chronic oral dental infections. and those infections were causing a significant amount of issues, in which case we've done some different things to help, whether it's oil pooling or using specific oils with oil pooling, not just coconut oil, and different herbs and things like that, which at times have actually gotten rid of the infections. But otherwise, I'm usually recommending they see a biological dentist that really help take care of those things. I would say outside of infections, occasionally, if someone's not eating red meat, I'll see that be an issue. But I would say most of the people I'm seeing, they're eating red meat, so that's not usually a thing. Super interesting side note though, Dr. Tim. We haven't actually talked about this before, but I have a number of different just Indian patients here in Texas, and a lot of them don't eat red meat. And so, what's interesting though is like I see a lot of people that are maybe vegan, vegetarian, and they actually don't have low iron or low ferritin on their labs, which I've always found to be super interesting. Now, have I lab tested all of them? No, I haven't. But I have seen enough where I'm like, you would think for as little as they eat that their body would be just starving for iron and things like that. But I have some different thoughts on that. I think some of it might go back to like just different genetic predispositions where their body tends to hold on to it. I know some people say that, we get iron through spinach and things like that. I think that's kind of a bit of BS. I think there is different forms of iron in those, vegetables and whatnot, but it's not, they're not super bioavailable forms, I would say. But Dr. Tim, I'll throw it back to you. Any thoughts on in adding to that, either agreeing or adding in other things as well that you found as far as being at the root of a lot of these different anemic issues and different deficiencies?
Well, I think you really just hit everything that needed to be hit with iron deficiency anemia. Infections, most common cause of that. So infections will feed off of iron. They'll eat up all of our iron. That's why a lot of times it'll cause constipation and it'll make you feel worse if you take it. But another important thing that I think is important to mention is so whenever we have various parasitic, bacterial, fungal infections, whether it's SIBO or other issues, you're going to have fermentation that occurs in the gut. You're always going to have production of acetaldehyde as there's alcohol breakdown, all that stuff. And it's also a byproduct of just the microbes being killed off in the gut. And so as the immune system kills that stuff off, it'll produce that as a byproduct of that reaction. So what is acetaldehyde? It is the next step in alcohol breakdown. That's why if there's fermentation occurring in the gut, you're going to have to break that down. But then also, it's just a nasty chemical that is used to kill off things in the gut. And so with that being said, it's a nasty chemical that we have to break down. And there's 4 necessary cofactors that are used to break it down from acetaldehyde into acetic acid. 4 cofactors are vitamin B2 riboflavin, vitamin B3 niacinamide, iron, and molybdenum. Iron is also on that list. And so if you have a ton of acetaldehyde that's being produced and needs breaking down, all 4 of those cofactors are going to start to go lower and lower and lower as time goes on. Well, iron and B2 can both feed microbes in the gut. And that's why those who have infections are often deficient in these things. The B2 deficiency can cause dry, cracked lips and then almost like an orange, crusty stuff that happens in the corners of the mouth. All of that is textbook riboflavin B2 deficiency, totally independent from what we're talking about today. But there are certain signs and symptoms, including iron deficiency anemia, that tend to go hand in hand with gut infections or just various fungal, parasitic, and bacterial infections. So anyway, I think it's important to talk about how you're also demanding more iron to break that stuff down too.
Yeah.
In addition to that,
kind of a nasty.
I'm sorry, go ahead.
Yeah, I was just going to add, it's kind of a nasty cycle, right? Where you have the infections feeding on the iron, and then they give off these toxic acetaldehydes, byproducts, which need iron to break it down. And so that just leads to all kinds of brain fog, all kinds of gut issues, all kinds of problems there. Yeah.
And if you don't deal with the acetaldehyde toxicity that's present, it's going to downregulate the immune system, and you won't be able to kill all microbes in the gut. And so if you require iron to fix this, it can be kind of an uphill battle because you don't want to feed the microbes with iron, but you need iron to help clear out the acetaldehyde. And that's where red meat is so important. A lot of people are like, oh, red meat, it's going to make your cholesterol high and all this stuff, and it's not good for you. You need iron from red meat in order to deal with a lot of this stuff, because if you just supplement iron, your body's just going to, the microbes are just going to eat it super, super quickly. Whereas if it's bound and within your food, it doesn't happen so readily, and it's not going to irritate things quite as much. So your body can actually absorb more of it. So anyway, but with the B6, B9, B12, all that stuff, all B6 pernicious anemia and the B9 and B12 are different. They still kind of boil down to the same nutrients. So vitamin B6 is the textbook female hormone detox nutrient. And I've said that time and time again. It is necessary in almost every reaction in production of glutathione, cysteine, methylation, all kinds of stuff to package and prepare hormones to be broken down in the liver through their individual detox pathways. So if you are having an estrogen surge numerous times throughout the month, because you have a cycle every month, you're going to require a lot of B6, B9, B12 to break down all of those hormones. So in addition to that, if you have blood sugar issues, if you have insulin issues, if you have cortisol issues, all sorts of hormone issues are centered around poor blood sugar regulation, you're going to demand a lot of B6, B9, B12. So that's why we always harp on fix your blood sugar, fix your blood sugar. Do the dysglycemia diet, 3 meals a day, 5 hours apart, all that stuff. It's so incredibly important because it's not just health, it's health in other ways. A lot of times fatigue and anemias, all that stuff are rooted in just not having enough nutrients to make good blood cells, and where are those depleted from? A lot of times it's blood sugar dysregulation and inability to detoxify hormones. That'll make things worse. But in addition to that, I think something that needs to be said too is B6, B9, B12 depleted from anything that's going to demand methyl donors. Anything that methylation does to detoxify things, you're going to deplete B6, B9, B12. Well, one of the most common things that people have every day that is going to deplete these resources is very, I would say, addictive, and people are super, super tied to it. Dr. Joel, can you take a stab and guess getting there?
So addictive, messes with, we're talking about methylating nutrients, dopamine, all these things. I'm going to guess it's either related to food or it's related to entertainment.
Food, drink.
Coffee.
Coffee, caffeine. There we go. Okay, you got it. All right, so caffeine. So what allows us to detoxify caffeine is methylation. So if you are not methylating properly, you're more sensitive to caffeine. But two, you're going to demand more of these resources to break down caffeine. Well, if you just hammer yourself with caffeine, blood sugar, juice, whole shebang, you're going to run out of resources to make red blood cells properly. And so that's where anemias can develop there. So I would argue that if you have a serious caffeine problem and you're down the road of just, I'm insanely fatigued, I just don't feel good, nothing works, all this stuff, not only are you messing up your hormones, but I would be willing to bet that your anemic markers are suboptimal as well, as a result of caffeine addiction, all those things. So ditch the caffeine. It's not that hard. It might be. I totally understand. It is not super easy. Also, I'm just kidding. It can be difficult, but most of the time when patients that come in and they're like, all right, I got to feel better. I'm super fatigued. I got all these problems. If I say stay away from caffeine, they do a whole lot better, and they feel a whole lot better. And it makes it easier once you gain some traction and start feeling better to stay away from it. And a lot of times people they'll drink it as a Band-Aid because they just feel so tired all the time. Well, if you deal with the underlying issues contributing to why you're tired in the first place, you're going to feel better and you're not going to require it. So, hey, just ditch the caffeine. So, beyond that, I mean, that's all I would really on big time regarding nutrients that are tied to anemias. A lot of the other stuff is, like you said, post-hemorrhagic. So just from essentially bleeding out. If you got in a car accident or, God forbid you got stabbed or shot or something, or some sort of serious accident where you're just bleeding profusely, you're going to have a normocytic, normochromic anemia just from losing too much blood. So there's nothing wrong with your red blood cells. There's just not enough because you're just bleeding out. Versus like hemolytic anemias, autoimmune stuff. Yeah, there's a whole lot that we could get into there, but it's not like it's just a one nutrient thing that we can talk about. It's everything that we talk about with the immune system and Th17 cell production and autoimmunity. That it's just, this is not the episode for that. Just know that there are autoimmune conditions that can cause you to break down your red blood cells. And if you're more interested, listen to our autoimmune podcast. But beyond that, what I think is super important to mention is what sort of lab markers, say somebody has labs and they want to know how can they identify these things on labs. What are the big things that you are looking for? And what are the big things that you tell patients, hey, this is what this means on labs?
Yeah, so I'd say when it comes to the different anemias, you want to run your CBC, your complete blood count, and you want to get that, of course, with differential, right? So the differential part is more so referring to the immune system, but it's still important. And as far as cost, I think it's like a $2 difference in cost. But when it comes to the CBC, you're looking at overall red blood cells and the amount of red blood cells. You're looking at hemoglobin. You're looking at the MC, the mean corpuscular volume, like we discussed. You're looking at hematocrit. You're looking at the mean corpuscular hemoglobin concentration. You're looking at all these guys. There's a huge, and we probably should have mentioned this earlier, but there's a huge difference between the lab range that you're going to have on your standard or traditional test results. On the very right, it usually says reference interval, and that's the range that they want to see those numbers in. Those ranges are really too large if we're talking about optimal ranges and being as healthy as possible. And so what we want to do is we want to use optimal ranges or functional ranges, which are usually much tighter. And this is going to show us if your body is functioning healthy or if your body is just suboptimal. The way I kind of explain it is that the standard ranges, also called pathological ranges, will tell you basically, is something way, way off, or are you, quote unquote healthy? Whereas the functional ranges are going to show you if you're actually functioning healthy and optimal, or if something is off. So with that said, there's a list of functional ranges. Dr. Tim, should we go through those? Let's maybe just hit some highlights on those real quick. I have them pulled up here, so I'll just kind of go through them real quick. Red blood cells for men. Cool. For men and women, they're a little bit different. But for the red blood cells, for men, we usually want to see those be 4.4 to 4.9. For women, 3.9 to 4.5. For hemoglobin, we usually want to see that about 13.5 to 14.5 for women. For men, we usually want to see it about 14 to 15. That's grams per deciliter. We'll just kind of go down the list. The hematocrit, we want to see about 37 to 44% for females. For men, 39 to 55%. The mean corpuscular volume, which is the size of the cells, we want to see about 85 to 92. Remember, when that gets larger, that indicates that the cells are more immature, and that's essentially going to indicate usually a B12 deficiency or B9. We have the mean corpuscular hemoglobin concentration, and that number is going to usually be about 32 to 36 grams per deciliter. And then we have, where did that go? Okay, perfect. Then we have the mean corpuscular hemoglobin level there that we want to see roughly 27.7 to 32. The last couple things, red blood cell distribution width, that's kind of like the average size of the cells, because the cell's size can vary. 11.7 to 15% is where you want to see that optimally. And then platelets, usually we want to see those about 155,000 to 379,000. Without going into a lecture on all of these numbers and so forth, maybe at some point we'll do that. But that's kind of the functional ranges. So if you have labs and you're not sure that your doctor is really getting to the bottom of things and you want to understand the labs better, look at it with those ranges, and you'll generally see that, oh, there's actually some things that are off here that we are, maybe seeing. It's not off massively in the way that you're going to die soon, but it's definitely off in the way that, hey, there's something going on here. Dr. Tim, kind of lost track here. What does that kind of cover some of those things, and then where are we going to next year?
Yeah, so that covered, CBC, all that stuff, big things there, things to keep eyes out for. That, other things that we can look at to assess B vitamin status, homocysteine, stuff like that. So if homocysteine goes high, all that's telling us is we're not converting homocysteine back into methionine through methylation, or we're not converting it to cysteine to then be used in other pathways, glutathione production, all kinds of stuff. And so homocysteine goes high. That's a direct 100% marker that you are low in B6, B9, B12, and just those would be a good idea. You can just directly measure B vitamins on labs too, so it doesn't necessarily need to be through other things. Beyond that, your CV, say it goes high. Well, you know that there's a B9, B12 deficiency. Say it goes low. Well, that's a good indicator that you have a B6 deficiency. Even if it goes high, it could mean that you're low on B6. It just all depends about the bigger picture. It's not like a steadfast thing. If it goes high, though, you are definitely low on B9 and B12. Absolutely. Yep. Well, it doesn't necessarily mean that you're low on B6. It's not an absolute thing. Could be, but not 100%. B6 can go both ways, I would say that. Just all depends. So,
yeah, for sure.
Honestly, beyond that, I'm not off the top of my head, not really too sure what other things that we can measure.
I mean, the other thing that we've talked about, but we haven't mentioned here in the last minute or so, is just the iron panel, right? So you have iron and you have ferritin. Iron being the iron in your blood, and then ferritin being more of the iron stored in your tissues. Most doctors run one or two of them. You really want to run both, as we both do. But in those levels, your iron, you want to usually see about 85 to 130. Ferritin, optimally, there's different thoughts on it. From some of our mentors, Dr. Kessinger, he says he likes to see it from 50 to 100 for ferritin. Usually when ferritin spikes up, it's due to inflammation. When it spikes down, usually due to some kind of anemic issue. But it's good to check both of those, because you want to see, things. You want to see the levels in the blood be good. You want to see the stores of iron be good as well. And sometimes you'll see that the actual iron level itself looks fine, but the stores are low. And usually that's an indication that you're basically on the early stages of anemia, and your body's like shifting and pivoting to try to get the iron out into the blood and things like that. So, but I think that pretty much wraps up the list of labs. So, Dr. Tim, we're running out of time here. We need to wrap up. Let's do this. Let's kind of quickly walk through what are some of the top points that you would recommend. Hey, someone has an iron deficiency issue. How would you consider going about that? And I'm going to grab my charger as you do that.
Well, so I'll just chunk it all together. If you have any of these anemias, most common ones are going to be B6, B9, B12 deficiencies, or iron deficiency anemia. If you have any of those, one, fix your hormones, fix your blood sugar. So we always recommend what we call the dysglycemia diet. Basically, that just entails eating 3 meals a day, 5 hours apart. Enough protein and fat in each meal to carry you from one meal to the next without feeling hungry, hangry, jittery, all that stuff. Get that all sorted out, and then don't eat any carbs. If you're tired after you eat, that's too many, and you're going to cause insulin issues. So get those things sorted out and start supplementing with B6, B9, B12. Methylguard Thorn is a great methylated B complex. It doesn't contain B2, so you're not going to have to worry about feeding any microbes in the gut. I would keep eyes out for that. If you're doing a methylated B complex, avoid ones that have B2. If you haven't knowingly cleaned up your gut, you haven't talked to a doc who's been able to examine you and figure out that's a problem. That's going to be the best possible thing that you can do to fix B6, B9, B12 deficiencies. Beyond that, with the iron deficiency anemia, clean up your gut. Find if there's any infections going on that are depleting yourself of iron. Most common reason that I will see that anemia in the office is you have some sort of infection somewhere that's feeding off of those or that iron. Fix that, you'll be good to go. So in the meantime, though, don't take iron, because it is going to make those microbes worse. So it sounds counterintuitive, but the reason that it usually causes gut issues, constipation, diarrhea, you name it, kinds of stuff, is because it's not doing you any good, because the microbes in your gut are eating it. So, yeah, clean up your gut, fix your hormones. It'll be good to go.
Yep. No, agreed. And that's essentially what I'm emphasizing with patients is that most of the time these deficiencies are coming from infection. So we got to get to the bottom of those. A lot of times in our visits, of course, we're jumping in with the systems healthcare and figuring those things out. And I'm usually very early on, either the first or second visit, recommending, hey, I know this iron supplement you've been told you need to be on for forever, and you know all these different things. But number one, most of the time people are saying, hey, they didn't even notice a difference in their function when they started it. And then number two, the labs really haven't changed. And so that plus I'm usually finding some infections feeding on these things. I'm usually recommending they stop the iron, and then we go in with herbs and address things. Dr. Tim, we talk a lot about herbs and different treatments. We talk, of course, I think it's important to mention here, is that usually when we find infections, there's usually one or two herbs specifically needed. Let's say there's a bacterial issue, an overgrowth in the gut. There's probably about 25 to 30 different nutrients, different herbs that we'll check for patients. And usually they're needing one or two. And the crazy thing is it's different for every person. You can try different herbs and herbal blends kind of as a shotgun approach, but usually we don't find that to be super efficient and super effective. But generally following like a low FODMAP diet to prevent feeding the fungus and bacteria can be helpful for a time. And then also having the right herbs can be super helpful. With as specific as that is, obviously if you can find someone that does muscle testing and can check those herbs and things on you, that's awesome. And definitely recommended. Otherwise, there's so many things you can do to support your overall gut balancing. Things like getting plenty of movement, managing stress well, obviously eating well, being careful of what you're eating and drinking. The more processed foods and junk foods that you eat, the more your gut is going to be disturbed and imbalanced. And so that's where really honing in on nutrition can be huge. Limiting fermented foods like probiotics, kefir, kombucha, all those things can be helpful as well. And just again, another reminder, if you are showing either on labs or with muscle testing that there's a deficiency in iron, B12, cysteine, copper, any of these things, chances are there's an infection feeding on it. And that's what you really want to get to the bottom of to fix with that. All right, Dr. Tim, any last comments? Otherwise, let's go ahead and wrap up.
Last comment is we said this was going to be a 25-minute episode. And here we are at 37 and a half, like usual.
This is better. This is better than most. Usually we're pushing 45.
We are, but let's not push any further. Let's wrap things up. So I'm Dr. Tim Augustiniak here at Functional Center down in Bentonville, Arkansas. If you want to find me online, my website is draugustiniak.com, draugustiniak.com. Links to all the socials and contact info on the front page. If you have any questions, comments, concerns, or suggestions for future episodes, reach out, let us know.
Yep, likewise. And I'm Dr. Joel Miller. You can find me online at drjoelmiller.com. You can find me on Instagram fairly easily. Guys, thank you so much for tuning in. Thanks for listening. And we hope you guys have enjoyed this. Reach out if you have any questions. If there's any other topics you want us to cover, like Dr. Tim mentioned. And we'll plan on seeing you guys next week in the next one. Peace.